Hello, welcome to another episode of The Lancet Voice. I'm Gavin Cleaver.
And I'm Jessamy Bagenal. It's July 22nd, 2020, and coming up on today's episode, we've actually got a little bit of hope in the COVID-19 era. And we speak with Editor-in-Chief Richard Horton about the successful Phase 2 trials of 2 COVID-19 vaccines and what that means for now and the future.
And then Jessamy chats with 2 public transport experts about the risks of virus transmission in trains, planes and automobiles. And then we chat modelling. You'll have seen, especially recently, that scientific modelling is a prominent tool for showing how decisions made now affect the future. But how does it work? We asked Kathleen O'Reilly of the London School of Hygiene and Tropical Medicine to explain how a modeller predicts the future.
But first, you'll almost certainly have heard in the last couple of days about the successful early trials of what we're calling the Oxford vaccine and the China vaccine. Gavin spoke with Lancet Editor-in-Chief Richard Horton about what this progress means and how far there is yet to go, and what's gone wrong with global cooperation during the COVID-19 crisis.
Richard, in a nutshell, then, how promising are the results of these papers?
Well, thanks, Gavin. The results of these 2 randomised trials are extremely encouraging, and I think should give us optimism that we're making good progress on the way to a vaccine to protect human populations from COVID-19. They are only Phase 1, Phase 2 studies, so we do need to wait for the full randomised trials in Phase 3 populations, but I think that we have good reason to be hopeful for the future.
So these 2 papers consist of the commonly referred to as the Oxford vaccine and also the China vaccine. So what's the difference between the 2 vaccines? And are they currently at the same stage of development, roughly?
Well, the China vaccine is a recombinant adenovirus vectored vaccine. And what it's doing is expressing what's called the spike gene from the coronavirus. And it's based upon a virus that was widely prevalent in Wuhan. The Oxford virus is a chimpanzee adenovirus viral vector, and that also expresses the spike protein as well. So they do have differences, but they are also related. They both have a very impressive impact on generating both antibody-related and what's called cellular-related immunity. And that, I think, is the great step forward that both of these studies are telling us, that both arm response can be provoked, can be stimulated by these 2 vaccines. And that's why I think we can be hopeful as we go into the Phase 3 studies.
Now, of course, as you mentioned, these are Phase 1 and Phase 2 combined results. So obviously that's something to be cautious about. But could you summarise, I guess, what we still need to keep in mind about these vaccines, if you will, what we should remain cautious about with these results?
Well, what these results are telling us are that these 2 candidate vaccines are safe. There were no major adverse reactions from either vaccine. The kind of adverse reactions that one saw were symptoms like muscle fatigue, general malaise, feeling feverish, headache, and of course, because it's an intramuscular injection, pain and sensitivity at the injection site. And these kinds of adverse reactions can be relatively easily prevented by taking, for example, paracetamol before you actually receive the vaccine shot. So that's the first thing. The vaccine is safe from these studies. It's also, and this is a word that is used by vaccinologists, and I'll explain what it means in a second, it's immunogenic. And by immunogenic, I mean it's stimulating the immune response. As I was saying, these 2 arms of the immune response, the humoral response and the cellular response, antibodies and T cells, these 2 vaccines are stimulating both arms of that immune response, and that's very important. It's not telling you that these 2 vaccines are efficacious or effective in preventing COVID. They're simply telling you that the first base, so to speak, or maybe even the second base, has been reached. that we've got safety, they're well tolerated, and they're doing the right things immunologically that we need them to do if the vaccine is going to work.
Right, but we have no proof that these vaccinations prevent COVID-19.
No, we're not at that stage yet. Right now, if you take, for example, the Oxford trial, that's being tested in phase 3 studies in not just in the United Kingdom, but also in Brazil and in South Africa, where, of course, there's a lot of transmission of the virus at the moment. And they're also testing that vaccine in some of the high-risk populations that we know about, people who are older, those who have chronic disease, people who are health workers on the front lines of the pandemic. So we will get extremely valuable and useful information from those phase 3 studies, but they're not going to be available for some months.
So looking at the broader picture then, obviously vaccine development is a huge priority for pretty much every country in the world at the moment. It's something that the world is in desperate need of. So we have this massive acceleration of vaccine research. Of course, the kind of thing that would normally take years is actually being done in weeks, in months. What challenges are posed by accelerating this timetable so hugely?
When Tony Fauci was giving evidence to the United States Congress recently, he was asked about the usual time it takes to produce a vaccine. And the evidence that he gave, he said 7 years. And he was asked, what's the fastest time a vaccine has ever been produced? And he gave the example of a Zika vaccine, which took about 18 months. Although the Zika outbreak, the outbreak had pretty much ended by the time there was a vaccine. So it never was fully brought to fruition. But let's say that 18 months has been the shortest time so far. I think we're looking at roughly the same time course here. And there's a real trade-off, because what you're trying to do is you're trying to get a vaccine that works and also a vaccine that is safe. And it's very important that one is not going to rush a vaccine into clinical use until you can be as sure as you must be that the vaccine is safe. Now, inevitably, no vaccine is 100% effective or 100% safe, and it won't be taken by 100% of people. So you're trying to make sure that you've got all of the evidence available to show that it is maximally effective in as many populations and high-risk populations as possible, and that it's maximally safe. So we do have to go through these very important tests before a vaccine can be released for general use, if we do reach that point, because we do need to be sure that it is as safe as possible as well as effective. There are also other interesting twists. In one of the studies that we published, the study from China, they found that the immune response in older people wasn't as effective, wasn't as strong as it was in younger people. And so as they're moving on to do phase 3 trials, they're now going to introduce a second dose, a booster dose of the vaccine for older people that will hopefully stimulate their immune systems more, because it looks like they need to be stimulated more to get a good response to the vaccine. So these twists in the vaccine story are going to take place over the course of clinical testing. And that's why I think we should be optimistic about the direction of travel we're going in, but not so ambitious that we think we're going to get a vaccine, for example, by the end of the year. If we have a vaccine by the end of 2021, we will have done incredibly well.
So you mentioned there the twists and turns, of course, in the story, I guess, of these vaccine developments. I think one thing it's worth talking about, I guess, when we think about these twists and turns, is the global state of affairs and the state of global cooperation between different countries, between different actors in this storyline. So why do you think that global cooperation currently seems so fragmented when we're looking at the kind of overall global tackling of this virus?
Yeah, I mean, it's very fragmented, and in some ways it's understandable. Governments have a first duty to protect their own publics, their own people, and so they're going to do the best they can to make sure they've got enough vaccine for if and when it comes to protect their people. But the danger of that is that many countries will lose out, and only the strongest country, the country with the most money, will win. I think if you take a global perspective, then I think most people would agree that those who should have access to the vaccine first are those who are most at risk of developing severe, even fatal disease if they become infected. And we know enough about this virus now and the disease it causes to know what those risk groups are. Older people, people who are living with chronic disease, black and minority ethnic communities, people who are on the front line of the epidemic, that's to say people who are working in healthcare settings, people who might be working in supermarkets, people who are working on mass transit systems, people who are coming into contact with other people all the time. Now, those are the groups that need to have access to the vaccine first before the rest of us. And if we could agree that through some sort of global convention or understanding, resolution passed at the World Health Assembly, some mechanism that takes place to agree that those are the groups that gets the vaccine first, that would be a huge step forward. Right now, there is a real danger that those groups most at risk will not get fairly or equitably treated if a vaccine does become available. And that should be a cause of not just global concern, but actually global shame if we're not able to find an agreement to protect those most vulnerable groups first.
So, I mean, really hopeful results there, Jess. I mean, there's still a really long way to go, obviously, but it's kind of incredible the progress that's been made in such a short amount of time on these two vaccines.
Yeah, exactly. And there's so much other work going on. So this is just one approach that's underway. So the other approaches that people are using are to use the virus itself in some form of either being inactivated or a live virus. So, examples that we have in this sort of day-to-day now,
live attenuated
vaccines include the MMR, chickenpox, and then inactivated examples of polio. So that's kind of a very tried and tested method, but it does take a little bit longer for the most part because you have to be absolutely sure that those viruses aren't going to, be harmful to people. So there's a lot of trials underway using part of the virus. And then there's this form of platform, which is the sort of adenovirus or another virus. So they essentially get some genetically modified virus and put in some of the SARS-CoV-2 genes inside it. And then the virus shuttles it into our cells, and hopefully our cells read it and respond to it with some kind of immune response. So that's what both these trials are using, that type of approach. And then there's some other work going on, which is using DNA or mRNA, and also protein subunits and virus-like particles. So there's an awful lot of work going on in this space.
I think one of the interesting things about these two sets of vaccines is that not only, obviously the timetable is extremely accelerated. We're doing what, as we were saying, we're doing in months and weeks what we would be doing in years normally. But actually these approaches to the creation of a vaccine are themselves unusual as well, right?
Yeah, so what's really interesting about this type of approach is that, they are promising, they are a modern kind of platform, but actually there aren't many other vaccines that use this particular approach. So the only one that's been approved, although not kind of fully proved in that it protects against the disease, is the Ebola vaccine. Otherwise, there's a rabies vaccine, which is used for live animals to sort of immunize them against rabies. But there aren't other vaccines that we use this particular method at the moment.
I think since we put these papers out on Monday, and obviously there was a slight leak the week before, I think it's really shown the level of interest, obviously, in these vaccines is absolutely massive. It's huge. As we're recording this on Monday, I think every single newspaper has, even the Daily Star has the vaccines on the front page. But I think it's important as well to sound notes of caution about it. The timetable at the moment, if the Oxford vaccine is successful, looks like it might be around the end of 2020, start of 2021, that it can actually start being rolled out. And of course, the government's already bought 100 million, or is it 300 million doses of this vaccine. But it might be the case that this is a vaccine that is partially effective. It might only take the edge off some of the symptoms, for example. And while that would be great and very useful and fantastic, especially in case of a second wave, it still might be the case that we could be years down the line before we get something that's actually fully immunogenic when it comes to COVID-19.
Yeah, there are so many things to think about. So, I mean, this particular vaccine, you know, as Richard said, what it shows at the moment is that it is immunogenic, that it does make your cells respond to something. But seeing as we have so little understanding of the correlates of protection or how we're meant to protect ourselves from this virus, we really don't know what that means. We hope that it means that it gives you immunity to it. Whether that's true or not is something that we still need to do a proper trial on. And then there's the sort of other aspects to think about with this particular, you know, type of platform. So using these adenoviruses has got a slightly sort of contentious past, in that this was the approach that was used in the early 2000s to try and develop an HIV vaccine. And what happened there was that actually they ended up having to stop those trials in 2007 because there was a concern about the type of adenovirus, this AD5 that causes the common cold, and people having some kind of a response to that, which then affected whether they were sort of more or less likely to get HIV. So, you know, there is still a long way to go. There are still things that we might find out. I mean, in those particular cases, those HIV trials were then started again with a different population who had already got existing immunity to that virus that they were using to transport the HIV sort of genes into. And that proved to be safe, but it didn't work. There's that kind of technical side to think about. But then there's also the side of, you know, whether this is going to work in the elderly. We've spoken before on this programme about the elderly having a poorer sort of immune response to most things, and being able to get that kind of immune response with a vaccine is very difficult. The hopeful things about these two studies is that, in the elderly, it did make some kind of response, although it wasn't as much as with young patients. And then again, you know, there's also this sort of issue of whether any kind of immunity would last for a long time and how we might do boosters.
Of course, and that's something that really comes out when you have these long-term trials of these vaccines. Normally, these years-long trials, you come out with at least an awareness of how long protection, if it's there, would last. But obviously, the timetable acceleration in this case doesn't allow for us to monitor anyone for that long.
Yeah, so it's really hopeful. But as you say, you know, there is still quite a long way for us to go to be sure that this is going to really make a difference to how we're all living and whether we're able to get back to the things that we were doing before the virus.
One of the many, many unanswered questions about virus transmission is to what extent public transport is a risk. Jasmine spoke with Manu Sasidharan and Giorgio Hadjimitriou from the Department of Engineering at Cambridge University, and they talked about the impact public transport has on COVID-19 transmission.
Manu, perhaps you could just tell me kind of where we are at the moment in terms of public transport and safety for COVID-19.
Given the limited understanding that we have of how things work around COVID-19, and of course the lack of a vaccine, the transport sector can contribute greatly to tailoring public health interventions of human mobility reduction and social distancing. There's, of course, a trade-off that needs to be achieved between the potential public health benefits of sort of curtailing public transport during a pandemic like COVID-19, and thereby delaying the community spread, against the socioeconomic impacts of curtailing or reducing that human mobility. So that trade-off needs to be achieved so that we have the near normal functioning of our society.
And I guess that trade-off is sort of particularly pertinent when we see the figures that, you know, the London transport, I think that they lost 90% of their income during lockdown. What plans are underway to try and make public transport safer and so that, you know, they can fill up that capacity? I read an amazing, you know, statistic of the 9 million people that are within London, 60% of the commuters use public transport, which essentially equates to 325,000 people during rush hour getting onto trains every 15 minutes. How, from an infrastructure point of view, is it possible to deal with that while also making it safe?
It's good to mention that during the lockdown, we had an 80% decreased use of public transport compared to normal times. At the moment, walking and driving is back to normal levels, while public transport use is still 40% lower compared to 2019. So there are many things that should be done to go back to normal. We observe a significant shift from public transport to driving and walking. And if people are going back to work, then there should definitely be some travel restrictions and social distancing measures. They should continue. And since we should keep the social distancing measures, so there are many things that need to be done. In the short future, I believe that governments should definitely see in improving the infrastructure for walking and cycling, since it's ideal for many reasons like exercising and environment and avoiding transmission of viruses. So our focus should go to this perspective in the near future.
Yeah, I mean, that makes complete sense, I guess, just instead of kind of trying to make public transport very, very safe, we need to also focus our efforts on these other aspects of transport, which are just inherently much safer for people.
And if I may add, the linear transportation networks of roads and railways and its associated infrastructure, they're considered as the largest public-owned asset in most of the countries, and it's not that different in the UK as well. But what we're sort of seeing is that in a post-COVID-19 world, where the economy of many countries are likely to suffer, we need to identify and implement cost-effective and user-centric strategies for managing our transport infrastructure, because of the fact that the current world, much of this infrastructure is managed or maintained under constrained budgets. And with the future economic uncertainties, we would have to find the best way of going forward. And at the same time, it is also imperative to recognize that we have a once-in-a-generation opportunity to deliver a transformative change in decarbonizing transport. If we look at COVID-19 as a disruptive event that has brought about a range of changes in our travel behavior. So as a human mobility choice, as what my colleague said, as a human mobility choice in post-COVID-19 world might incline towards public transport, we also need to make sure that it doesn't bring about huge, significant risk of increased greenhouse gas emissions and environmental problems.
How might those discussions start, just on a kind of practical level? You talk about the sort of transport infrastructure being, you know, for the most part, some of the largest aspects of government-owned economies. How can we use this point to move away from things?
So, as I mentioned earlier, the current way by which we manage or maintain our transport infrastructure is often in what we say is a silo management system, where we sort of look at a particular infrastructure and sort of take decisions on that area. But once we take a step back and think, we need, at the end of the day, transport and its infrastructure as a public service. So it needs to work efficiently for the betterment of our citizens. So if we are to tailor our strategies in a way that we look at a whole system perspective or a whole transport system perspective, where we consider strategies which is a win-win for every single stakeholder in the transportation system, including the environment, that would be a decision. That would be a starting point. And there are currently plans to bring in that whole system approach. Even discussions has been happening, and even pushes from the Office of Rail and Road Regulator talking about the advantages of bringing such a whole system approach into picture.
Thanks, Manu. And just kind of getting back to COVID-19 and public transport, what evidence is there so far for transmission of COVID-19 on public transport that you're aware of?
We investigated the correlation between human mobility and COVID-19 related deaths. So we started by seeing how the government measures affect human mobility. So we divided time into some periods where from the beginning of 2020 until the 8th of March, we had an increased use of transport and of walking and driving. But then from the 8th of March and until the 23rd of March, where we had the general lockdown, there was a gradual decrease of mobility. After the lockdown, after the 23rd of March, public transport use was decreased at the level of 80%. And then from the beginning of May, when some of the measures were lifted, we gradually increased the use of public transport. How is this related to COVID-19 related deaths? So the daily increase of deaths of a pandemic can be modeled by a generalized logistic growth. And we know that based on previous studies and based on previous pandemics. So as I said, we divided time into some periods until the 8th of March, until the 23rd of March. And we moved on 18 days later, since the mean time between exposure to COVID-19 virus and the reported death is 18 days. So we used these dates to examine how the increase in number of deaths data until these dates can show how affects deaths. So our conclusions were that with some predictions, our conclusions were that if there was no human mobility reduction at all, then the deaths would be several times higher than the current number we have. If there was only advice and recommendations for avoiding non-essential traveling, and then the number of deaths would be again higher than the current number, but lower compared to no reduction of human mobility at all.
There are other studies as well, but I suppose what we're saying is that the assumption is that because we've reduced the number of people traveling on public transport and we've therefore reduced the deaths, that there is some kind of causal association there, which obviously can't be proved, but can be modeled, as you say. And I just wondered, now that we've kind of got this potential of aerosol transmission, what's the ventilation like on public transport, on different types of public transport, say on the tube, on trains?
So WHO has very recently recognized the fact that there is a risk of airborne transmission in specific indoor locations, such as crowded and inadequately ventilated spaces over a prolonged period of time with infected persons. So we're, of course, not sure of how long that prolonged period of time should be and all that. But there needs to be enough social distancing measures, and at the same time, safety options if wearing masks while traveling on the public transport.